We are continuing with the esophageal disorders in gastroenterology. Will what is the most likely diagnosis? A single word, progressive or from solid to liquid, is the most important clue to the diagnosis of esophageal cancer. Look for age 50 or older, dysphagia first for solid, followed to dysphagia for liquid, association with prolonged alcohol and tobacco use, more than 5 to 10 years of GERD symptoms. Achalasia has no association with alcohol or tobacco use. Here, esophageal cancer is associated with prolonged alcohol and tobacco use. For diagnosis, endoscopy is indispensable since only a biopsy can diagnose cancer. Barium might be the best initial test, but no radiological test can diagnose cancer. CT and MRI scan are not enough to diagnose esophageal cancer. They are used to determine the extent of spread into the surrounding tissue. PET scan is used to determine the contents of anatomic lesion if you are not certain whether they contain cancer. PET scan is often used to determine whether a cancer is resectable. Local disease is resectable and widely metastatic disease is not. For cancer, the radiological test is never the most accurate test. Treatment: no resection equal to no cure. Surgical resection is always the thing to try. Chemotherapy and radiation are used in addition to surgical removal. Stent placement is used for lesions that cannot be resected surgically, such to keep the esophagus open for palliation and to improve dysphagia. Esophageal spasm. The two forms of spastic disorder, diffuse esophageal spasm and nutcracker esophagus, are clinically indistinguishable. Both present with the sudden onset of chest pain that's not related to exertion. Therefore, at first, it's impossible to distinguish them from some form of atypical coronary spasm or unstable angina. They can be precipitated by drinking cold liquids. The case will describe sudden, severe chest pain, and EKG and stress test will be normal. Esophagogram and endoscopy also will be normal. DES and nutcracker esophagus can be distinguished only by the most accurate test manometry, which will show a different pattern of abnormal contraction in each of them. Barium studies show a corkscrew appearance at the time of spasm. Treatment: esophageal spastic disorders are treated with calcium channel blockers and nitrates. This is similar to the treatment of pharyngeal angina. PPIs can improve a number of cases of spastic disease. Tricyclic antidepressants can be used instead of calcium blocker. If all these treatments fail, sildenafil is an alternative to these drugs. TCA can be used instead of calcium channel blocker. Eosinophilic esophagitis. Patients with eosinophilic esophagitis have swallowing difficulty, food impaction, and heartburn. Look for a history of asthma and allergic diseases. Endoscopy shows multiple concentric rings. The most accurate diagnostic test is biopsy finding eosinophils. The best initial therapy is proton pump inhibitors and eliminating allergenic foods. If PPIs are not effective, the answer is swallowing steroid inhalers to allow the topical use of steroid. Eosinophilic esophagitis. We have one MCQ here. A 43-year-old man recently diagnosed with AIDS come to the emergency department with pain on swallowing that has become progressively worse over the last several weeks. There is no pain when not swallowing. His CD4 count is 43 mm3. The patient is not currently taking any medication. What is the most appropriate next step in management? Esophagogram, upper endoscopy, oral nystatin, swish and swallow, intravenous amphotericin, oral fluconazole. For explanation, The pills causing esophagitis, if they are in prolonged contact, are doxycycline, alendronate, potassium chloride. The question of the above answer of the above question is E, which is oral fluconazole. The most commonly asked infectious esophagitis question is esophageal candidiasis in a person with AIDS. Oral candidiasis or thrush need not be present in esophageal candidiasis. One does not automatically follow from the other. Although other infections such as CMV and herpes can also cause esophageal infection, over 90% of esophageal infections in patients with AIDS are caused by candida. Empiric therapy with fluconazole is the best course of action. If fluconazole does not improve symptoms, then endoscopy is performed. Intravenous amphotericin is used for confirmed candidiasis not responding to fluconazole. Oral nystatin swish and swallow is not sufficient to control esophageal candidiasis. Nystatin treats oral candidiasis. Here they have given the algorithm for management of infectious esophagitis. Dysphagia with HIV CD4 count less than 100. If yes, empirically start fluconazole. Then look for improvement. If the patient is improving, continue therapy and HAART. If no improvement, then perform upper endoscopy with biopsy. If ulcers are large, then most likely it is CMV. Then therapy for cytomegalovirus is acyclovir or foscarnet. If ulcerations are small, then it's most likely to be herpes simplex virus. Therapy is acyclovir. Rings and webs. Stick house syndrome. Dysphagia from solid food associated with Schwartz-Chiering. Schwartz-Chiering and Plummer-Vinson syndrome both give dysphagia. Schwartz-Chiering is often from acid reflux and is associated with hiatal hernia. This is a type of scarring or tightening, also called peptic stricture, of the distal esophagus. Plummer-Vinson syndrome is associated with iron deficiency anemia and can rarely transform into squamous cell cancer. The iron deficiency is not caused by blood loss. Plummer-Vinson syndrome is more proximal. Plummer-Vinson syndrome is more proximal. Rings are easily detected on barium studies of the esophagus. Schwartz-Chiering is associated with intermittent dysphagia and is treated with pneumatic dilation in an endoscopic procedure. Plummer-Vinson syndrome is treated with iron replacement at first, which may lead to resolution of the lesion. In the image, Schwartz-Chiering is visible as a distal narrowing of the esophagus. This is easily found on barium studies. Zenker diverticulum. Zenker is an outpocketing of the posterior pharyngeal constrictor muscle. There is dysphagia, halitosis, and regurgitation of food particles. Some patients suffer from aspiration pneumonia when the contents of the diverticulum end up in the lung. Zenker is associated with bad smell and severe halitosis. Diagnostic test or treatment. Zenker diverticulum is best diagnosed with barium studies and is repaired with surgery. There is no medical therapy. Do not answer nasogastric tube placement or upper endoscopy. These are dangerous to people with Zenker diverticulum and may cause perforation. Scleroderma. These patients present with symptoms of reflux and have a clear history of scleroderma or progressive systemic sclerosis. Manometry shows decreased lower esophageal sphincter pressure from an inability to close the ileus. The management is with PPIs as it would be for any person with reflux symptom. The disorder is simply one of mechanical immobility of esophagus. Manometry is the answer for achalasia, esophageal spasm, scleroderma. Next, we'll continue with esophageal perforations.